Today, as part of this DNB Academy program, we are regularly running surgical audit from MR Hospital. And today will be our audit presentation. First presenter is Dr. Milind Alokji. He will present audit for.
Sir, Dr. Prasanjit will present for Unit 1.
Okay, fine. Dr. Prasanjit, you can share your screen and start. I was requesting all bed in charges to join. Abhishek has joined. Okay.
Good morning, our respected faculty members and other participants. I am Dr. Prasanjit Bosu and I am going to present the surgical audit for December 2022 for Unit 1. Summary includes total OPD days 9, total admission day 10, total OPD patients 1158, which includes old 358 and new 810. Eight total time in OT. Lab includes 32 hours and 30 minutes. Open table, we have spent 42 hours and 30 minutes. Total number of minor OT days 9 and total number of mortalities are 2 in number. Here summarized table: elective admission includes 34, emergency admission 22, elective operation 32, emergency operation 16, mortality 2 and morbidity 2. Elective admission in which hepatic biliary system and pancreatic system and chronic calculus cholecystitis, in which we do lab cholecystectomy in total number of 8 cases and open cholecystectomy in total number of 2 cases. In one case, cholelithiasis with choledocholethiasis, we do CBD exploration with T2 insertion. Intraoperative T2 cholangiogram also done in that case. In GI and perianal other cases, we have gastric outlet obstruction in a case of CA stomach, in which we do gastrojejunostomy with omental biopsy. In another cases, we carcinoma. The patient presented with mass in carcinoma of in ascending colon and hepatic flexure. We did extended right colectomy for this patient. In fissure, a single case of fissure in and also there, in which we did lateral intersphincterotomy. And in hemorrhoids, there's 2 cases in which we perform open hemorrhoidectomy. In a case of recurrent appendicitis, we did laparoscopic appendicectomy. Groin surgery, incisional and ventral hernia, there are 2 cases in which we perform anatomical repair. In cases, 8 inguinal cases, we did lichen tension-free mesh hernioplasty, and in 2 cases, we did herniorrhaphy. There is a single case of varicocele, unilateral varicocele, in which we did open varicocelectomy. A single case of hemosis is also there, in which we did circumcision. In breast and endocrine, a single case was there which presented with bilateral fibroadenoma. We did excision of both sided fibroadenoma in right and left breast. Emergency admission in which there are cases in which first case is obstructed incisional hernia, in which we did anatomical repair. Two female cases in acute, in another case acute intestinal obstruction, in which a mass is present in the ascending colon and ileocecal junction, in which we did exploratory laparotomy and we found a growth in ascending colon. Acute intestinal obstruction is also there, which in which we did exploratory laparotomy with loop ileostomy. And there are 6 cases of perianal abscess in which we did IND under TIVA, and diabetic foot ulcer. There are 4 cases of diabetic foot ulcer in which we did debridement. Granuloma. Hello.
Hey, please carry on.
Excision of pyogenic granuloma. Total number of 6 cases are there, and lipoma excision total 7 cases, and Charis procedure in which there are 5 cases, and sebaceous cyst excision 12 cases, and excision of corn is 1 case. Morbidity, there are single morbidity and 2 mortality cases, 1 male and 1 female. Morbidity of 56-year male patient who is a case of mesh hernioplasty in POD2 developed seroma. Total leukocyte count was 8,200. Swab sent for culture sensitivity, but there is no growth or organism was found. It is managed conservatively by regular dressing. In first mortality, a 75-year female who presented with subacute intestinal obstruction and intra-abdominal mass and bleeding per rectum. Patient is investigated and found to have growth involving the ascending colon and hepatic flexure. Pre-operatively, patient is optimized. Patient underwent extended diathymic colectomy. Post-op was shift ICU. POD0C was conservatively managed in CCU up to POD3. Then on POD3, stay in ICU. Up to POD3, there was uneventful ICU stay, but vital signs stable, blood parameter were in normal range, chest physiotherapy and incentive spirometry was started. Patient was not able to ambulate properly. On POD5, she developed shortness of breath and severe hypoxia. SpO2 falls below 88% and patient is intubated, but patient eventually developed cardiac arrest and succumbed to death. In second mortality, a 56-year-old patient is presented in ER with chief complaint of distension of abdomen and history of non-passing of stool for 7 days with shortness of breath. Patient was conservatively managed outside for these 7 days. Exploratory laparotomy was done. Intraoperatively band adhesion is noted in the distal ileum. Adhesiolysis is done with loop ileostomy. Patient was immediately shifted to CC1 with ET tube in situ, and patient is put on invasive ventilation. On POD1, patient developed sudden cardiac resuscitation was tried, but ROC cannot be achieved. Thank you.
Abhishek, I find you have done 4 cases of anatomical repair.
Sir, this is
not our unit, sir.
Unit 1, sir. Dr. Kuntal and Dr. Kors.
Oh, yeah. Kuntal is joined? No.
Sir,
No.
no, sir,
What is the details about these patients? Because you see, most of the ventral hernias, we prefer to have a mesh repair. So what is your rationality for going for anatomical repair? Ventral hernia, 2 emergency, 2 elective. Give us some idea.
Sir, the
Give us
size
some
of
idea
defect
about these hernias, the neck of the hernia, content, uh, how is the patient. So, because anatomical repair is not preferred, because once you have some gap, if you want to have anatomical repair, the main point is creating some tension.
Sir, the size of defect is less than 2 centimeter, and mostly the content of the hernia are omentum.
Okay.
So we
All
prefer anatomy.
four patient has identical defect.
Yes, sir. Yes, sir. Identical, similar defect, less than 2 centimeter in size, and
Okay.
omental content, mostly omental content.
Okay. And come to the first mortality. This patient had a right hemicolectomy. Okay. And
Yes, sir.
you are trying to say that till third post-op day, patient has uh, being maintained everything, and chest everything was done. So, what is the reason for developing breath shortness of breath and hypoxia in on
Sir,
fifth post-op day?
probably the patient has aspirate some content. On POD 3 onwards, she allowed oral feeding,
Yes.
and probably she aspirate and
No, why a
used
conscious patient should aspirate?
Sir, if I may intervene, sir, this particular
Yeah.
patient, sir, she was an elderly female, and sir, she, although she underwent the extended right hemicolectomy and post-op, she was maintaining everything, but sir, the patient was extremely demotivated herself. She refused to cooperate with us. To even so the main issue was that she was unwilling to ambulate. Even by POD 5 here, sir,
Mhm.
she refused to get up from the bed. We could only once manage to along with the two, three people in the staff, we just once we were able to manage to put her on her feet. Otherwise, she was so demotivated to do anything or even continue. That sir, it
Okay.
was very difficult to progress this patient ahead, sir.
You see, this
Sir,
actually this elderly female who are maybe anemic or whatever, in that case, you have not done a stoma. So it was a primary anastomosis. So one has to be very vigilant to look for any leakage. And
sir,
there is no evidence of leakage.
no, sir, there was no evidence of leakage. The per-abdomen, sir, it was soft. IPS had come by the second post-op day in the evening, sir. Third post-op day in the morning, sir. And so that is why, sir, the main issue here was not that we any surgically or other than that, sir, with respect to vitals or how the patient was being resuscitated, everything was going according to how we would expect, sir. But the only issue was the patient was completely not, we could not motivate her to uh, mentally come out of a state that she has been bedridden and that she is sick. Because sir, as a small background, sir, she had gone through a lot of losses in her family recently, with her own spouse and her daughter-in-law, and
No.
she
Okay. Okay. Was
lacked that
she on?
will to live.
Yeah. Was she on low molecular heparin? Because
Yes, sir, she was given. She was given
elderly
DVT
lady, she
stockings,
might
sir.
have
Low
some.
molecular heparin was started. Yes, sir, they were given, sir.
Okay.
DVT prophylaxis was done, sir.
Okay. Okay. And about the second case, this was probably a adhesive intestinal obstruction. Was the bowel gangrenous, Prashanjit?
No, sir. Some changes there, but
Then
completely
what is the rationality of doing a ileostomy in this patient? Because it's in band obstruction. If you lyse the band, the obstruction should go. Why you add a ileostomy? Who was the surgeon?
Sir,
Who was the emergency
there,
surgeon?
yes, sir.
Who was the emergency surgeon?
Sir, the Dr. K. Chakraborty, sir, who is
Okay. Okay. Now, as PG, you
and
should also try to find out what is the rationality of doing a procedure.
sir, there is some changes. There is Dasky.
If there is some change, you see, when there is some change in the gut, you decide it is totally non-viable, it is borderline, or it is viable. If
Sir,
it
it
is
is
borderline,
borderline.
you
It is
wait.
borderline.
If it is borderline, you wait. give hot compress, give 100% oxygen. And if
It
you
is
feel that this is getting changed to a normal side, you need not do a resection.
it is given, sir, in intraoperatively given. The thought was that prophylactically for loop ileostomy, later on we did if when patient optimized, we perform reanastomosis
No,
because
no. What I'm saying
patient
is,
patient's vital is also not stable. His saturation is
no,
around
that is what I'm
75.
saying. If the
Yes,
patient has got a poor GC, vital is less, in that case, what I'm trying to say is, if the gut is viable, there is no reason for you have done a resection in this patient, no only a loop ileostomy.
for loop ileostomy was done.
Only a loop
Resection is
ileostomy,
not
sir.
needed.
That is what I'm
Resection is not
saying.
needed.
In a gangrenous bowel, that segment is not suitable for a ileostomy. If you feel the gut is gangrenous, you have to resect that segment and then do the ileostomy. And if you say it's a borderline, you can take a chance. You can always have a second look operation.
Sir, in this case, sir, we just did a temporary loop ileostomy in Cayman
No,
because the
I'm
distal
asking.
bowel was
If
severely,
distal bowel was?
sir, the distal bowel was severely distended, sir, and filled with
Distal bowel cannot be
stool.
distended. Proximal.
So sorry, proximal bowel, sir. Sorry, proximal bowel
So
was
you
severely
decompress.
distended, filled with stool, sir.
No, you decompress it, retrograde decompression. A proximal bowel will definitely get distended. In a distended bowel, you can decompress the bowel, retrograde into the stomach and aspirate.
Sir,
If,
in this case, sir, we had done an antrograde, sir. We had made a small rent and done an antrograde decompression,
no,
and then that
this
rent
is
only be taken for a ileostomy, sir.
no. This is not a good technique of decompressing bowel on table. Why do you make a enterotomy and then for that enterotomy you do a ileostomy? Because ileostomy is a morbid procedure. If it is required, you have to do ileostomy. If it is a band obstruction, lysine, the band should relieve the obstruction. If the obstruction is relieved, the proximal distension will gradually go down. And it's not necessary that for proximal distension you need to do an enterotomy and do ileostomy for that part. And what happened to this patient? Why this patient died?
So this patient, sir, actually he was being managed outside for 7 days. So overall, he was not his vitals were, although when we took him for the OT, he was stable, but post-operatively his pressure was not maintaining properly. So even in the CCU, he was on NORAD support and he was not extubated on table. He was intubated and he was shifted to the CCU and he continued to be on NORAD support, sir. Sir. By the evening also his NORAD support was only slightly tapered and he was not put off the he was not extubated, sir. Again, sir, next day morning when we had seen the patient, he was still intubated and NORAD support was similar, and said that by afternoon suddenly he developed a cardiac arrest, sir. Up till then, sir, 3 ABGs had been done and the evening ABG and the morning ABG were within normal limit. But sir, the third ABG that we found that was done just before the patient developed a cardiac arrest that had severe metabolic acidosis, sir.
No. My point is, if the patient was being treated for 7 days outside and it's a case of adhesive obstruction, what are the indication for emergency laparotomy in this patient? Was this patient show some signs of strangulation?
So when the patient had come to us, the abdomen was severely distended. It was so we could not found it. We could not find any IPSS. So the Riles tube was filled with stool. We did a Riles tube. Flying stool was coming out from it, sir. And the patient was also not very. Sir, I mean, it was the decision was taken to do a laparotomy. Sir, since in 7 days he was being managed outside. Antibiotics and proper coverage, everything was done, but there was no improvement.
How much time you take to optimize the patient after admission?
Sir,
Time
the
of
patient
admission
was
to
at
the theater?
time of admission was 5 a.m. in the morning, sir, and we took the patient for OT at around 1 p.m. in the afternoon, sir. So in 6 hours, we gave the patient fluids. The way hemoglobin was checked, hemoglobin was within normal range. All of the blood parameters were within normal range. We took over 6 hours to resuscitate this patient, sir. Pre-operatively, we did one ABG, and that was within normal limits, sir.
Okay. You see, these are the patient 56 years leading with obstruction. Once they have relieved the obstruction, these patients should go through This patient does not have a strangulated segment of bowel. Patient was not in probably gross sepsis. These are the patients that should be in the
Yes, sir.
post-op period. They should come up.
Yes, sir.
Okay.
Sir, actually, we were expecting till the second day in the morning, because since the ABG report were also fine, we were waiting for the patient to be extubated. But sir, then it was actually a sudden cardiac development, because we got a call suddenly from the CCU that the patient has developed a sudden, and they could not resuscitate the patient.
Okay. We'll pass on to the Unit 2 presentation. Who is presenting?
So Dr. Mehul will be presenting.
Okay. Mehul, you can share your screen.
Yes.
Good morning, everyone present here. Surgical audit for December 2022 of Unit 2 General Surgery. Total number of OPD days were 9, total admission days were 10, and total OPD. Total OPD patients were 1,266. Total number of elective OT days were 9. Total time in OT, in table 1 lab, 32 hours, 15 minutes. Table 2 open, 27 hours, 20 minutes. Total number of minor OT days, 7. Time in minor OT, 7 hours, 30 minutes. Time in emergency OT, 4 hours. Total number of mortalities, 2. There were total 29 elective admissions, 21 emergency admissions, 26 elective operations, 13 emergency operation, 33 minor operation, 2 mortality, and 1 morbidity. In hepatobiliary and pancreatic and splenic surgeries, there were 12 laparoscopic cholecystectomy done for chronic calculous cholecystitis. 2 open cholecystectomy was done for chronic calculous cholecystitis. 1 periampullary carcinoma, it was managed initially, then referred to higher center. And 2 carcinoma GB with metastasis were also referred to higher center. In gastrointestinal and perianal surgeries, 1 ileostomy closure was done for post-op exploratory laparotomy with ileostomy. 1 feeding jejunostomy was done for carcinoma of stomach with gastric outlet obstruction. 1 open appendectomy was done for recurrent appendicitis. In hernia and groin surgeries, 1 TAP was done for unilateral inguinal hernia. 1 Lichtenstein mesh hernioplasty was done for unilateral inguinal hernia. 2 herniorrhaphies were done for unilateral inguinal hernia. 1 onlay mesh repair was done for epigastric hernia. 1 anatomical repair was done for umbilical hernia. 1 onlay mesh repair was done for para-umbilical hernia with divarication of recti. And 1 circumcision was done for phimosis. In breast and endocrine surgeries, 1 hemithyroidectomy was done for a left-sided solitary thyroid nodule. Emergency operations, 1 exploratory laparotomy was done for acute intestinal perforation. For foot ulcers, incision and debridement was done.
What you did? Exploratory laparotomy and perforation. You did a primary closure or did a stoma?
No, sir. Resection anastomosis was done, sir.
How old it was? What are the history like?
Sir, she was a pregnant female.
Pregnant?
Yes, sir. Actually, sir, this was a refer from gynae, sir. Gynae department. So that female
what is the
went.
period of pregnancy? Period of pregnancy?
Yes, no, sir. She had delivered the baby, sir.
Oh, post
pregnancy, yes, sir.
Okay.
Oh, sir, sorry, sir. She wasn't pregnant, sir. She went for DNC, sir.
Oh,
she went for DNC.
Don't
5
confuse.
days.
This
yes,
is a
sir, sorry,
post DNC gut injury.
Yes, sir. Post DNC gut injury, sir.
Yes.
So for that, we.
What is the time gap? What is the time gap between the DNC being done and the laparotomy?
So 5 days.
5 days. My goodness.
Yes, sir.
And you did a primary anastomosis.
Yes, sir.
Who was a
Yes.
emergency surgeon? Dr. Abhishek?
Yes, sir. Dr. Abhishek Bhomik, sir.
Okay, carry on.
So incision and debridement was done for 1 foot ulcer. IND was done for 1 IND was done for cervical abscess, 2 for perianal abscess, and 1 for inguinal abscess. Uh, for acute gallstone pancreatitis, there was 1 acute gallstone pancreatitis for which conservative management was done. 2 acute alcoholic pancreatitis, also conservative management was done, and 1 acute calculus cholecystitis, conservative management was done. 3 appendectomy were done for acute appendicitis. 1 exploratory laparotomy with right hemicolectomy was done for acute intestinal obstruction. There was 1 case of appendicular lump which was managed conservatively. 1 stab injury patient's local exploration and repair was done. There were 3 foot cellulitis, 1 in male and 2 in female. So the conservative management was done. Minor operations, wedge biopsy from ulceration, sir, 1. 8 excision of sebaceous cyst, 6 lipoma excision, 2 granuloma excision, 3 ZX procedure, 12 incision and drainage of abscesses, and 1 foreign body exploration. And emergency interventions, 1 chest drain insertion was done, sir. There is 1 morbidity and 2 mortality. Morbidity 1, 48 years lady underwent emergency appendectomy on POD3. Purulent discharge along the incision line with no foul smell was noted. Sutures were removed and area was drained. No fever and total leukocyte count was normal. Daily dressing was done over the next 4 days. Subsequently, the discharge amount reduced. Secondary suturing was done on POD8. Patient was discharged on POD10 with follow-up advice of regular dressing. Mortality 1. A 60-year-old male came to the ER with recurrent acute intestinal obstruction for which he was earlier conservatively managed outside. Exploratory laparotomy was done. Intraoperatively, ileocecal mass was noted and right hemicolectomy was done. The patient was initially stable till the morning of POD2. In evening, he became delirious. So psychiatrist was referred and routine investigations were sent. Only sir WBC count came to 13,000 and rest all the parameters were within normal limits. On POD3, he was shifted to CCU for respiratory difficulty and was on NORAD support for hypotension. Respiratory distress was managed initially with oxygen therapy and other supportive management as in guidance with the CCU staff. On POD4, the patient was intubated and later developed cardiac arrest. Resuscitation was tried, but he succumbed to death. And mortality 2, 35-year-old lady who was a case of bile duct injury post-laparoscopic cholecystectomy. On POD12, she developed biliary peritonitis and was in shock. Patient was resuscitated. She underwent exploratory laparotomy and peritoneal lavage was given. A 32 French ADK drain was placed at the hepatorenal pouch of Morrison. Patient was shifted to CCU on POD0 with endotracheal tube in situ and was on invasive ventilation. POD1, the patient was doing well initially. The TLC count was 14,000 and urea creatinine was normal and the urine output was also improving. On POD2, trial was given to extubate the patient, but the patient eventually developed cardiac arrest and succumbed to death. Thank you, sir.
Prashni, may we come to OT time? OT time? How much
Yes.
time spent in emergency?
The emergency minor OT, sir.
Total time in emergency OT?
7 days. Emergency OT. Yes. Emergency OT.
We have not mentioned. Okay, fine.
No, sir, not
Come to the in the mortality. Is it the same patient who had? No, this is a separate patient. Huh?
So,
This patient was done last month. This
yes, sir. This
lab
patient
coli?
was done. No, sir, not the lab coli, sir. The bile duct injury, sir. Yes, sir, lab coli, sir.
Post lab cholecystectomy.
Yes, sir. This was
The
done
lab
last
coli
month.
was done outside or in
The last
Bangalore?
month was missed, so we added this month, sir.
No, the same patient who was.
Yes, sir. The same patient who underwent sir, lab coli, but had a bile duct injury, sir, intraoperatively. Sir.
No, this was supposed to be the last month. Is this second case or the only case?
No, the same case, sir.
Okay.
So we
The
missed last
point is,
month.
you see, the point is what I like to want to discuss in this patient is, you see, the patient who has got lab bile duct injury. This patient on PUD 12, you said patient has biliary peritonitis. Was the patient discharged from the hospital?
No, sir. Patient was not discharged, sir.
A patient was not discharged, then this patient who is leaking, we should have some suspicion that patient is leaking from the injury site. What was done for this biliary injury on table?
Sir, sir, if I may interrupt, sir.
Yes, please.
Sir, actually, we had discussed this case initially in the morbidity year. So this patient on table, when we detected the injury, it was a very small injury. We had put an infant feeding tube through the rent laparoscopically, and patient was initially fine. But maybe
You have
in
put
the
the feeding tube to the rent.
To the rent laparoscopically, and initially it was draining bile, and there was nothing much in the
You see, putting a feeding tube, and
Yes,
that feeding tube was brought outside.
Yes, sir. Like just like a T tube, but we also thought of a T tube, but the rent was so small, we thought that it would not admit a T tube properly. Also, so a 6 French infant feeding tube was put, sir.
And that was brought outside.
That was brought outside the abdomen.
And how
Just
she
like
behaved for 12 days?
the initial around 5 days, she was fine, but then the infant feeding tube also stopped draining bile. There was nothing much in the drain. Patient's abdomen was uh, initially fine, but later she developed a bit of pain. We did USG also, which was initially normal, but later around POD 10, she started feeling pain abdomen. And then the pain abdomen gradually increased. We did a
In
USG also.
that case, second
Yes, Yes,
laparotomy was for biliary peritonitis.
Yes, right.
What you did on the second time? Just drainage?
Yes, sir. We did a laparotomy. We could not approach the operative site properly due to severe adhesions. So we did proper
Most of the
lavage and
time, in this situation, doing
yes,
a
sir.
laparotomy is a more morbid procedure.
Yes,
If it's feasible, it is better to have a laparoscopic drainage of this biliary collection, and it works well. You
Yes,
see,
sir.
the laparotomy is a more invasive procedure, and most of the patient does not do well with a laparotomy. So,
True,
a
sir.
laparoscopic drainage is better than this. Okay. So, patient has gross biliary sepsis, I feel.
Yes, sir. Initially,
Yeah.
patient improved after the surgery, but as Mehul has mentioned, but later she suddenly deteriorated and suddenly had a cardiac arrest in the ICU. CCU.
Mhm. Okay. Chalo. Next. Okay. Thank you. So, audit for Unit 3, General Surgery. Who is presenting? Milind?
Dr. Diptaman, sir.
Okay. Diptaman, please.
Good morning, sir. This is the audit for Unit 3. Good morning to my respected teachers and dear colleagues. Next slide, please. Total number of OPD days were 9. Total admission days 11. Total OPD patients were 1120, which includes new patients and also old patients. Total number of elective OT days were 9. Total time in OT 27 hours 15 minutes in lab and 32 hours 20 minutes in open. Total number of minor OT days was 18, including the ER OTs and minor OTs, everything. And total number of mortalities was 1. Now, in elective admission cases, total was 64. Emergency admission 17. 44. Emergency operation 4. Minor operation 39. Mortality 1 and morbidity 2. In the hepatobiliary and pancreatic spelling surgeries, chronic calculus cholecystitis, laparoscopic cholecystectomy was done in 17 cases. Chronic calculus cholecystitis, there were 3 open cholecystectomy cases. In choledicrolithiasis with cholenithiasis, open cholecystectomy with choledoadenostoma done in 1 case. In GIT and perineal surgeries, colorectal CA case was there, which was managed with palliative hemicolectomy and end-to-end ileocolic anastomosis. This is a 1 male case. Then there was a case of liver access, which underwent diagnostic laparoscopy and drainage of liver access. This is also a male case. Then there are 2 cases of fistula in ano, which underwent fistulectomy. There were 2 recurrent appendicitis cases, which were managed with laparoscopic appendicectomy. In the section of hernia and groin surgery, there was a case of ventral hernia, which underwent IPOM plus. Incisional or ventral hernia cases were there, 1 which underwent mesh hernioplasty. Bilateral inguinal hernia underwent TAP hernioplasty. Unilateral inguinal hernia underwent Liechtenstein mesh hernioplasty. Total was 8 cases. There was a case of mesh infection. The infected mesh was extracted from right-sided inguinal hernia. Umbilical hernia case was 1 which underwent main hernioplasty, and there were 2 cases of phimosis which underwent circumcision. In the breast and endometrium section, breast lump case was 1 which underwent excisional biopsy from the right breast, and there was a case of CA breast which was referred from outside, which underwent BCS with axillary dissection in the left side of breast. In the emergency operation sections, there were 1 cases of left-sided obstructive hernia, which underwent left-sided hernioplasty with orchidectomy. 2 tarsal cases were 2, which underwent incision and debridement. Peptic perforation case was 1, which underwent exploratory laparotomy with modified Grant patch repair. Continuing with the emergency admissions, acute gallstone pancreatitis cases were 2, which underwent conservative management. Acute calculus cholecystitis cases were 2, which underwent conservative management. There was a case of peripheral arterial disease, underwent conservative management. Next, foot cellulitis with DM and HTN cases were 2, which underwent conservative management. And there were 2 cases of diabetic foot ulcers, which underwent debridement and dressing. In the minor operation section, there were injection polydecanol. There were 4 cases, admission of severe cases 15 cases, plain extraction cases were 7, ID cases were 4, granuloma injection cases were 5, and injection Kenacort were given to 4 patients. In the morbidity and mortality section, there were 2 cases of morbidity and 1 case of mortality, which I will discuss in the subsequent slides. In first morbidity, this was a 23-year-old male. He was actually alcoholic and also addicted to some addictions like ganja, cocaine, this type of things. He underwent exploratory laparotomy due to peptic perforation. On the POD2, abdomen becomes slightly tense, bowel sounds are audible, USG whole abdomen within normal limits. Patient was kept off NPM and IV fluid. And for the next 2 days, patient was also kept for NPM and IV fluid. Fast flutter, but gradually then abdomen becomes soft. There was no fever and CSC counts were normal. But he developed surgical site infections to some extent after the next 3 days. However, after regular dressing for the next 5 days, along with antibiotic coverage, the wound infection subsided and the patient was subsequently discharged. This is the case of morbidity 2. This was the elderly man admitted with cholecystectomy and he underwent open cholecystectomy cases. On the POD2, there were 6 cells discharged from the wound from one side. Suture was removed and side drained. but there was no fever and CRP count was normal. Draining dressing was done for the next 4 days. Subsequently, discharge also was reduced, and then after next 4 days, the patient was discharged as the wound site becomes healthy.
Diptomar, you don't think patient with abscess, liver abscess drainage has some morbidity? Diptomar?
Yes, sir. Yeah.
What happened to
Yes,
that
sir,
patient post-op? Liver abscess.
Sir, the liver abscess, sir, gradually his bile secretion decreased within the next
But he has 500, 700 biliary drainage to the drain side. Is it normal?
So, sorry, sir, that should have been included in the morbidity.
Yes. And what about mortality?
So there was only one case of mortality. Actually,
So
sir,
you discuss that. Yes.
So this patient actually admitted on admission day night. She was this elderly lady admitted during the night time of our admission day with severe wound infection in leg with uncontrolled diabetes, fever, minimal urine output, and disorientation. She was given conservative management and dressing done on the wound side. However, in the next few hours, she developed tachypnea, tachycardia, and very low BP and renal shutdown. This patient was already, sir, highly morbid from the time of admission. But within the next few hours, we quickly send the patient to CCU and given CCU type of management like ventilation, inotropic support, but we could not save the patient, sir. This patient died within 6 to 7 hours of our admission.
Where was she treated earlier?
Sir, she didn't get any definite treatment. Some local coax or some local treatment she was given. This was a totally neglected case. So this is the sole mortality we have in the last month.
Okay. Any question from any of them? Okay, we conclude the meeting today. Thank you.
Thank you, sir.
Thank you, Milind. Thank you.
Thank you, sir.
Thank you, sir.
Thank you.